Hi, everybody. This is Kevin with Garrison Dental Solutions, and have been standing by for a great program here tonight that Dr. Jared Johnson over in Iowa is going to be putting on for us. So we're super excited to have him here with us this evening. But before we get started with the program, I wanted to just review quickly kind of the process here this evening. So at the end of the session, right, probably 5 or 10 minutes after we complete it, we will send you an email that has the evaluation and quiz questions for this evening. You need to complete that in full, hit the submit button on the bottom, and when that comes back to us, we'll send you out your course attendance verification certificate. You need to stay tuned all the way through to the end because there is a course code that is given at the end here this evening, and you'll need that code to be able to submit your quiz and eval. If you're an AGD member, be sure to put your 6-digit AGD number in the space provided, and we will submit that to the AGD on your behalf. And there we'll have a email that we'll put up later on. If you have questions, let's say you don't get your quiz or you don't get your certificate, we'll put an email address up. Make sure you jot that down if you have any CE related questions. So, all right. So Dr. Johnson, you can see him there on the screen. We're going to go ahead and turn the program over to him. Take
All
it
right,
away.
thank you, Kevin. I appreciate being with you tonight. Thanks for everyone for coming out. I know it's been a challenging year for everyone, and you've probably been bombarded with Zoom CEs, so really appreciate you coming out and listening. Tonight, we're going to cover restoring adult teeth in children, and it can be very challenging, and I've made a lot of mistakes in my career, and I've really adapted very, very well to try to pick the best products that we can use in kids to have a long-term result for them and not have to redo work. I did a lot of work that I had to do over because I was putting the wrong material in. So I'll share with you some of those things and the failures and things that we can do to help improve care for our pediatric and adolescent patients. I do have to disclose tonight that I am receiving an honorarium from SDI North America and Garrison Dental. And I also am very, very proud to say that all the cases that I'm showing, except for one photo that was provided to me, are from my personal experience. This is, from my heart, my practice. This is what we do. These are the outcomes we can have. This is how you can be successful in treating permanent teeth in kids. So I'll share you my insights. We have a very good, very, very good track record now moving forward of picking the best material for each kid. And it's truly a balance, and it's a struggle with some of these kids that are very high risk. So they need your care and they need your help, and their teeth are definitely worth saving. I practice in Muscatine, Iowa. We're a town about 24,000 on a river here on the Mississippi River in Iowa, and it's a pretty good mix. I see about 70%, 60 to 70% Medicaid at my office, so we see a lot of high-risk kids. And then we also have a lot of blue-collar workers. We have a lot of manufacturing jobs in our town, and that can also play into the carries risk of the population that I do see. I also like to say that, these people here, these are my staff and my wife, office manager, in the middle with me, and I really couldn't do this without them, and they're very important. We do lunches every other week. We had one today where we have a staff meeting. I buy the office lunch and we go over stuff at the office, and they really appreciate that. Today we had we reward our staff. We draw names for their cheers for peers. They write a good deed in, and they draw their name. And today we had one of the staff give their gift to another. So they really do care about each other. This has been the hardest year, probably on them more so than on us, with everything going on and the shutdowns and everything. And I just want to make sure that everyone out here, just give your staff a thank you, whether you buy them coffee in the morning, do something for lunch, do something fun. There's still some things you can do that are positive to keep them going. They've really been through the brunt of this pandemic with us, and we wouldn't be here able to treat kids without them. So do something for them, whatever you want to come up with. Today we're going to be reviewing the materials that you want to use, and I'm really going to focus on, this is kind of the Bible, we called it in residency, of pediatric dentistry, the handbook. This is the most recent edition. Here I am with Dr. Art Nowak, one of the editors of the book, and he's been a wealth of knowledge and a great ambassador for pediatric dentistry. And I just want to point out that if you want to buy this book, it's definitely available for you. Published most recent edition in 2018. You can buy it online from the AAPD, and it's got everything you'd want to know about pediatric dentistry, and it's a very, very good resource for you. And we're going to highlight a lot of the things that are in this chapter of the book on restorative materials for the permanent dentition tonight. And I'll show you a ton of cases. So here are the materials we're going to go through. I'm not going to go through this list because we're going to hit them hard here. So amalgam is one. I don't do a lot of amalgam in my practice, so I do believe in it. I think it has a place in dentistry. One of the issues that we find with the amalgam is that parents right now, they want a cosmetic solution for their kids. So we'll show you some alternatives to those tonight, but it's definitely a nice material because isolation is not an issue. It can set up in moisture. It's not technique sensitive. It's got high strength. You're going to get that silver and the gamma phase corrosion, and that's going to, when you remove an amalgam, you have all that dark stain, and that's kind of similar to the SDF or silver diamine fluoride. You're going to have that, and that's going to help prevent recurrent decay. Disadvantages, aesthetics, and then also one of the big ones is 2 millimeters is the ideal depth. So if you have a small occlusal lesion and you're talking about prepping 1.5 minimal to 2 millimeters, that's going to destroy a lot more tooth. And we're trending towards an era where we're going to more minimally invasive dentistry, fewer root canals, fewer fillings, more conservative things. So composites can definitely play a nice role in those smaller lesions to do a composite and a sealant versus taking away a lot of tooth structure, which is going to definitely have an impact on the life of the tooth. We also have bonding agents that are changing now. Now we're coming out with new universal adhesives, which we haven't had before. This has always been confusing for me. We've got 4th generation, which has always kind of been the gold standards, where you have a bottle of etch, you have the bottle of the primer, and then you have the bottle of adhesive. You look at a kid that might be not so cooperative and you're trying to do all these 3 steps, if we can eliminate some of those, we have a better chance of having a more ideal outcome. I would say most people are probably using the 5th generation or the 7th generation right now, where you have etch and then the primer adhesive in a bottle, or you have all of everything in one. The universal adhesive, it's going to be a system where it can do 1 or 2 bottles, and you can really use it as a self-etch, a selective etch, or a total etch. So you get all the options of the other generations, and now we're seeing that the bond strengths, when we're using these for like a selective etch, we're getting some of the same bond strengths as the 4th generation cement, so or bonding agent, sorry. So that's a great thing. We started using universal adhesive at my office now. I do use Zip Bond right now. It's really nice because it gives you a consistent bond to the enamel and dentin. I'll show you the pictures here. You can get wet and dry bonding. We know that we want to have moist dentin, and sometimes the assistant might dry everything too much, but you're going to get consistent results. We know the moisture, if we leave that in the dentin, is going to pull in part of the bonding agent and increase the amount of tags for the mechanical retention you get. It forms a hybrid layer, very low film thickness. When I started out using Scotch Bond at my office, and I'd come back and my composites would have a radiolucency under them, and I wasn't sure if it was recurrent decay or if it was the bonding agent. And if they go to another office, they're probably going to get a new filling, and it may not be necessary. So low film thickness, it releases fluoride. It also bonds to some indirect substrates. If you're doing a lot of fixed work, it can be useful. And then it's also, you can use it if you're placing a sealant. You can use it as a top coat for the GI for the first few days while you're waiting for that GI to increase in strength. And you can also place it over your arm, GIs and GIs as restorative to kind of give it a little more strength while that material is taking its initial set time. If you look at the shear bond strength versus the different techniques, so we have self-etch dentin, where you're just applying the material, you're not doing any etch. You can see that's very high, in upwards of 20 megapascals. The total etch, you're also getting that as well. You're getting a little bit stronger with the self-etch. And then the total etch for enamel, you're getting a higher strength, opening up those tubules versus a self-etch or lower. So a selective etch is probably going to be more similar to the increasing the bond strength of what you'd want to do, but you can definitely use these universal adhesives for a total self, or whatever you feel is going to be best, and depending on patient behavior as well. Here you can see, we talked about wetting earlier. Here you can see if you do the dent and etch with the total etch technique, and here you can see the self etch technique. So this is why we're going to see a higher bond strength. So if we go back to that last slide, let me go back here one. You see a higher bond strength with the self etch. So why is that? It's because of the science. So this is the science, the microscopy behind this. So you can see the tags on the slide on the right. You're getting more penetration and more mechanical retention versus the left, and that's where you're getting a higher bond strength. So that's why a selective etch is probably going to be better with some of these new universal adhesives that are coming out. You can also see these shear bond strengths are pretty high to different materials, composite, ceramics, and metal. I'm not going to cover this because a lot of people probably aren't in pedo or probably not doing as much fixed work. I do some, but it's not an everyday thing. The application's a little bit different too. You'll apply the zip bond into the cavity for 10 seconds. You'll let it sit, and then you'll evaporate the layer. And then it's only a 10-second cure, which is nice because a lot of them are 20-second cures. So you're getting a little bit of reduction in your curing time for the application of this process. Some other adhesives, you want to apply it for 15 to 20 seconds, that's that first half, but you're saving about 10 seconds. And especially if you have a moist environment, you're having a difficult kid, it can save you a little bit of chair time to make sure you don't have blood flowing in or anything into the cavity. If we move into the composites, these are definitely very aesthetic. They're very conservative, like we talked about before, and they have nice finishing properties. They're going to have a very smooth outcome. They do require very good isolation. Your technique, you got to have absolute moisture control when you're placing it. Some people report more sensitivity with the shrinkage of the composite. We look at a 2% shrinkage factor, and that can cause some discomfort. Bond strength in the dentition can be a concern if you've got kids that are breaking number 8 and 9, and that's a challenge to restore if they're constantly breaking that off. And then we also see recurrent decay. We'll talk a little bit more about that when we get to the glass ionomers. We also have two types. We have a flowable and a packable, and there's different types that I use in my office. If it's really small or a small occlusal, we may use the flowable composite. They have less filler in them, so they're going to wear more faster, and they're going to shrink more than the packable composite. They're indicated for preventive resident restoration, which I personally don't do. I'll share you some slides with that. Class 2, Class 5, and then also strip crowns. The packable composite is a lot higher viscosity, a lot higher filler. It's not going to shrink as much, and it's going to last a lot longer. And this can be used for pretty much any restorative procedure within the permanent dentition. Luna is one of the composites that I've been using recently. It's a nano hybrid, so that's going to give you the strengths and aesthetics. It also has that chameleon effect. I know a lot of people got really excited about Omnichroma. This is kind of a similar product to that. It's going to have natural fluorescence and opalescence to the dentition. Very high flexural strength. So if you think about a kid and a front tooth, and it needs to be able to move and flex when they hit it. Otherwise, if it's so hard, we're going to have that fracture right off. It's going to give you a little bit more flexibility. It's got very high compressive strength. So if you think of something getting pushed together really hard, or an occlusal mastication, it's got very high compressive strength. Biggest thing for me is it doesn't stick to my instruments when I use it. I love that. I don't have to put alcohol or bonding agent on my instruments. And it's got a wide variety of shades. So here, if you look at the flexural strength compared to some of the other composites there, very, very high. And then also the compressive strength is, very, very high on compared to some of the other composites on the market. I will say composite contraindications. I got burned on this when I started practicing. My first kid, I was doing these high caries kids, beautiful composite restorations, and they were coming back in recurrent decay within a year. So I learned my lesson the hard way, and I'll show you some of those cases to help inform you of what's the best restorative material for the kids. Inadequate isolation, if you can't isolate it, might be better to place a resin modified glass ionomer. High caries risk patients, if they've got rampant decay, glass ionomer is going to be your friend. And if they have poor oral hygiene, I'll show you some cases, glass ionomer is going to be their friend. Bioactive materials are emerging. I will say we don't have much evidence on this. In lieu of time, I'm gonna miss covering this, but they do release phosphate and calcium ions in addition to fluoride. And I know a lot of people are one way or the other on these products, and there's a lot of discussion. So there's more to be learned in the research. Glass ionomers, These are a really good restorative material for the SMART technique. They do have a chemical bond to tooth, and then they have a high fluoride release. And this is where it's going to be very good for your high risk patients because of that chemical bond. It also has a very good coefficient of thermal expansion, so sensitivity, post-op sensitivity is going to be reduced for that because it expands at the same rate. If someone has something hot or cold, it expands at the same rate as dentin. So that's one way to use it as a liner and have a very good dentin replacement material. And then also it requires moisture. So if you have an uncooperative child and you're trying to do the SMART technique or something, this can work very well. Here we can see the marginal seal micro leakage compared to a flowable composite, very low micro leakage. This is Riva Self-Cure. And I also want to point out the chemical bond. So we talked about composite being a mechanical bond. The glass ionomer is going to be a chemical bond to the tooth. So you can see on the left side how thin that layer is between the gap of the glass ionomer and the different tooth structures, enamel, dentin, cementum. RMGI's got a little bit wider gap. You can see that, and then this study was looking at maybe if we reduce the particle size, you can see how small those particles are on the right. Can we get a better bond strength? And that apparently did not work well for dentin. So keep that in mind. The chemical bond is why we get less recurrent decay along with the fluoride release. So fluoride release here, you can look at Riva Self-Cure, very competitive compared to all the competitors on the market. Acid erosion, if they've got high risk, they're having lots of soda that has sugar and acid in it, we're not going to have acid dissolution here within the first 24-hour surface hardness. Very hard compared to the competitors, but this is the one slide I told you about. Dr. Jeff Knight sent me this. Glass ionomer is not good in really big restorations. It needs strength for bulk, but too big, it's not, there's just not enough there to keep that from fracturing. So keep that in mind when you're looking at a restorative material. It may be something that is great to buy you some time, but long-term, it may not last as long as some of the other options, such as a resin-modified glass ionomer or composite. So this is going to kind of have a mix also of, well, the advantages of the glass ionomer, but also the advantages of composite. One thing that I will say that it still does wear quite a bit more than a composite does, but less than a glass ionomer. So that's kind of the compromise that you might find. I use this for primary teeth class 2s, and I had very good success with it, and we've been very happy with it. I've also used it in quite a few permanent teeth in select situations, and it's worked out well too. I'll share you some cases here. Here you can see, same thing, like I showed you before in that study, very good long-term micro leakage. Compressive strength is competitive to the competitors. It's very good. One of the things I'll also point out is you notice the orange tip on these. That is one of my favorite things about the Riva Light Cure HV is that the tip on the product is orange, so it allows the product to sit for a little bit. It will set over time, but I can do upper right and a lower left class 2 with the same carpule, and I see 60 to 70% Medicaid, so I get reimbursed less, so it saves me money. So I really like the fact that this product can be used on the same patient twice versus some of the competitors. You set that down, you got to mix another one. That's another $8 to $12 that adds up over the course of your practice in the year. Flexural strength is high at 1 week. We talked about that earlier. Long-term wear resistance competitive to all the competitors. You'll see that these do wear. They're not going to last, you know, with the wear forever, but they don't get recurrent decay. So in a high-risk kid, it's probably a better option. Even if you're going to have some wear of the material, you can always redo that versus a new cavity, which means more tooth structure loss. I will say with isolation, cotton roll, this can be used quite well for sealants and class 1 restorations maybe, but I like to use the rubber dam isolation. We'll cover that. Isolite and dry shield, if I don't have that on for sealants, it's getting glass ionomer sealant. I want to be astringent to moisture control for how my products have the best ability. Anterior teeth, you could use an Optigate or something similar to that to help isolate those. Rubber dam isolation, I'm going to skip this in lieu of time. We'll cover this a little bit more in depth in the hands-on section that's going to be offered next month in December, and I'll cover a lot more other techniques. But just some of the, this from Joel Camp, some of the retainers that you can use that are useful for you. It's really easy. It's not that hard to place rubber dam. The kids love, the girls especially love getting a tooth ring, talking about jewelry. We have the floss that we put on. If they've got a movie on, we talk about an animal in the movie. If they have whiskers or if they have a pet at home, we give them whiskers, and you just work them through it. With the rubber dam, they love the Mickey Mouse and talking about a trampoline or raincoat. And a lot of the times after I've anesthetized the patient and I'll leave the room, the assistants will go through all this. So when I come into the room, they've already prepped the kid for everything that we're going to do. So it's less time for us explaining everything to them. For the restorative considerations, this is where I'm going to get into the bulk of the cases. So I'm really excited we got through all the science and got that out of the way. But without covering that, we can't really discuss the restorative challenges that we face. The factors are going to be the size of the lesion, how big is it, the extent, the depth. Also, the caries risk is really important. I would say that's probably one of the top factors is the patient's caries risk. You can have high, moderate, low. At my office, we do high and low. Just cuts out some confusion for everyone. And if you have, active lesions, you're high, and if you don't, you're low. And then from a restorative standpoint, I'll make the call. Just a little bit easier on your staff versus having a moderate, and they have to kind of help ask you all the time what it's going to be. Patient cooperation can be a big factor. I mean, I don't want to sedate a kid for an occlusal on a class 1 if it can wait. Maybe we can do a smart technique on that and delay it. And I'll show you some cases where that's worked out well for us today. Eruption sequence, I didn't include this, but I'll show you some of the hands-on. Maybe extraction of these first permanent molars is the way to go. Why are we putting this kid through a lifelong journey with this tooth when we could take it out and let the second molar and the third molar erupt in? It's going to be more predictable, especially with maxillary first molars with unerupted seconds, than trying to do endo and restoring the tooth. But we'll share some of that with you in the hands-on that's going to come up. Also, consider aesthetics. Not everyone wants to have an alloy. Not everyone wants to have a seamless steel crown. Not everyone, there's different factors. Not everyone wants to have SDF or a potential or stain in the teeth. So that may be something you want to consider when you're going through these options. So this is, I remind you, from the AAPD handbook. This is the algorithm for restorations in permanent teeth. If we have a tooth here where we have an incipient lesion or white spot lesion, this kid had braces, had poor oral hygiene in it and developed white spot lesions pretty much everywhere. Our options for this could be active surveillance, where we do nothing, but we place fluoride and reevaluate things. Resin infiltration or an icon type system could be something you want to do. I've had mixed success with that, and then also it doesn't work on everything, so it's hard to be predictable, especially with the expense. You could also consider arresting protocols such as SDF, but with the potential for some staining or discoloration. Most of these patients at my office, what I do is I will prescribe them a 1.1% sodium fluoride toothpaste, Prevenant, and if they want to come in every 3 months for a fluoride treatment, we do know we get a great reduction in decay with that. So that's what I do at my office. We're more the active surveillance for these anterior teeth. You can see cavitated enamel lesions here on the lower mandibular. We've got quite a few on 24 and 25. For a low caries risk patient and good isolation, you may be able to get away with composite or one of those bioactive materials. This kid's high risk. They have poor oral hygiene. You can see the gingival inflammation. These are probably better restored with an RMGI at my office than using a composite. If the kid changes habits, that can always be replaced. If their cooperation is not good, you could always consider doing an interim therapeutic restoration where you just place a glass ionomer in there and buy some time, or SDF followed by that. So those are also some considerations for this. But if they're cooperative and you can get through this and they're high risk, I would probably still stick with the RMGI in this case. I think you'll see less cases of coming back until their habits change, and then it's going to wear, it might just color a little bit, but it's going to last the patient a little bit longer. You can see a larger lesion here on tooth number 8, and you can see a composite restoration that's got some staining on tooth number 9. So we look at the moderate sized lesions. This could be treated with a composite bioactive material. I think full or partial coverage might be a little aggressive. In this case, I would probably treat this case here. You can see plaque, poor oral hygiene, resin modified glass ionomer is probably going to be your better bet. If their cooperation's not bad or poor, you could do the interim therapeutic restoration, selective caries removal. Then also SDF is definitely something you could consider here. So it just goes back to how the patient's going to sit in your chair, but this is definitely a high caries risk patient that's pictured in the photo. This is one that I saw. I didn't do these restorations initially, but this is a child or adolescent that came in braces, a very high caries risk. Here you can see someone else did composites, which we talked about, and I made the same mistake. These composites came in and there's recurrent decay. Some of them had fell out, and I learned my lesson from placing composites in the high caries risk kids. We had the brackets removed, and we ended up having a caries exposure on tooth number 8. We treated that with an MTA pulpotomy, and we placed glass ionomer in all of these teeth. And here's the post-op. Since we had the pulp exposure, we want to make a post-op so we can evaluate that. Here we are 2 years later. I know it doesn't look pretty, but there's no recurrent decay. Here you can see we had a failure on tooth number 7 with our indirect pulp therapy, and we're working through a root canal on that, but our pulp exposure healed fine. There's no apical pathosis. We don't have recurrent decay. These resin modified glass ionomers are holding up extremely well in this is an extremely high caries risk individual. I would love to show you the posterior teeth and the work we had to do on those. But this is a better solution. If I would have put composite in like I did when I started my practice, this would be a very, very challenging aspect. Here you can see this is another kid. You can see poor oral hygiene. This is just from brushing the plaque off in the teeth in the OR. I mean, that's a nightmare. And here, Riva Light Cure HV, a beautiful outcome here for this anterior tooth number 9. Another child, 7, 8, and I'm sorry, 8, 9, and 10 here, all restored with Riva Light Cure HV. Beautiful aesthetic outcome, very high caries risk kid, and that's going to last them a lot longer. Here you can see a high caries risk individual, anterior decay on number 8, restored with Riva Light Cure HV, and then a composite strip crown, full coverage we had endo done on tooth number 10. Very, very good outcome in this high caries risk kid and individual. So that's going to last long. If we look at pulpal lesions, you could do a composite if you wanted to, if it's a small access. If it's got a lot of tooth structure missing, like this one here, a composite or strip crown or full coverage. This one we were electing for full coverage. I will say once the kid needs it, we do it with knowing that the margin's going to show eventually down in their life. But I'd rather do something more permanent than something that's going to fraction. I have to keep redoing it. High caries risk, you can do composite, RMGI, or full or partial coverage. So those are options. Here's another case. Here's initial visit here. This was a 16-year-old with special health care needs, had a deep lesion on the mandibular anterior. Cooperation got poor. We had nitrous. The kid had done well before, got poor, and we had a pulp exposure. So we disinfected that with sodium hypochlorite. And then I just bulk filled biodentin in this case because that can last as an interim therapeutic restoration as well as a very good pulp capping agent. And let's give her some time, see her every 3 months. And we ended up having her come back on recall here, and everything looked okay. We're gonna give her a little bit more time. That was still sufficient, and her cooperation was better. Finally, she came back in 9 months. We had a pulp exposure here, and we just put in the biodentin, and you can see that dentin bridge that formed, and we were able to now restore this with the strip crown here. So she did well for that. We gave her some time, saw her every 3 months, and kept an eye on things, and we had a very good outcome. Didn't have to do root canal, didn't have to put her to sleep, special health care needs. Here's an immature tooth that had a fracture. I ended up doing apical barrier on it here. This, I think, case was neo-MTA. Here you can see later on the recall, very nice healing and a composite strip crown on this kid. So this kid was a lower risk, and we were able to do a strip crown. We'll cover that in the hands-on section as well. So beautiful result here, dentin bridging everything that you want to see for a very challenging situation of an immature apex. We're going to cover a lot of that in the hands-on, a lot of pulpal therapy too. Algorithm for posterior restorations. We're going to move into this. These are actually my teeth. So this is, I think, number 30 on me, where you can see an incipient cavitated lesion. And then also here, down here on number 20, I've got an incipiency. I've had these since high school. I use Prevenant myself. That's what we preach for my patients. I will say for the occlusal lesion, you could consider a sealant or resting protocols, and for the posterior teeth, resin infiltration. But I think a more conservative approach on occlusal lesions of a sealant, and then just working with the Prevident and fluoride treatments is the way to go for the posterior teeth. This is actually like an ideal boards lesion for class 2. I don't drill into those at my office. We wait. They're not going to get to the pulp in the next 6 months to a year unless they're extreme caries risk. I'm going to skip in lieu of time some of this coverage on sealants. We can move into that glass ionomer. We'll talk, I mentioned a little bit earlier about preventive resin restorations. Here you can see on the left here, that would not qualify for that. That's a sound tooth structure. Here you technically could. In my office, I don't do these. We seal them. A little bit deeper lesion, that would get a sealant at my office as well. This one's kind of between where, it might not be all the way into enamel, and you could definitely open that up. And then this one definitely needs to be restored. It's definitely cavitated. I don't have a picture for this one for the algorithm for posterior restorations in permanent teeth, but you could use a composite or bioactive material or resin. I'm sorry, not resin infiltration, not for that one. Sorry, that's a mistake. You can also use the amalgam bioactive material if the cooperation is poor. I would definitely consider a smart technique where you put on the SDF, put a GI in. And then also, I would say for these small occlusals or moderate sized occlusals, you can use an RMGI to buy you some time. Like, I think they're a great way. They may wear, but you can add that back up or apply the bonding agent at their recall visits to coat that again. But I've seen a lot more success in composites, especially in these high-risk kids. We can talk a little bit more about the SMART technique. I am going to move a little bit forward here just to cover a little bit more things that I think are important about the different materials. So let's cover this one. So there's 2 different SDF products on the market. I use both at my office. The difference between them is that the Riva Star is going to have silver fluoride in it instead of the silver diamine fluoride. So as the main composition. So if you look at the difference in the amount of fluoride and the silver in the products, you're actually getting more silver fluoride in the Riva Star, and that's the reason for the higher pH. You're also getting more silver diamine fluoride because of that reaction with the higher pH. So you're actually getting a lot more fluoride and a lot more silver with the product. So here you can see this is a slide from SDI. You can see inhibition zone from the Riva Star. And when we get to the science of that, it's really the uptake that matters. So we know that most of the reaction to the silver occurs within the first 60 seconds of the reaction. That's been published out of the University of Iowa. And we see that this is what's going to happen is you're going to precipitate the silver out. So you're going to get less penetration of the silver when you're doing 2 steps and higher penetration of the fluoride. And the fluoride is going to arrest the decay. The silver is going to work on the bacteria. And if we know that first 60 seconds, most of the reaction to the silver fluoride is done, then the fluoride penetration is going to give us a more mineralized tooth structure. Here you can see from Dr. Knight's study, the higher penetration of the fluoride and the shallow penetration of the silver. And also with the second step, you're going to be able to reduce the staining. This does penetrate 50 microns, and that's well within the range of indirect pulp therapy or 0.5 millimeter for avoiding having penetration into the dental pulp. You're also going to see higher, like I said, higher amounts of fluoride into these teeth that you're placing this on. You're going to see here, you can see on the right, the 2-step process versus just the silver fluoride alone is going to increase the amount of fluoride that you're getting into those. As far as staining, it will stain the teeth. Incorrect placement will stain the teeth. I did a few. I got this video. I applied these both products. Let me see if we can get this video going. This is a time-lapse video to these 2 extracted teeth, and here you can see the difference. The Riva Star is going to darken a little bit, but it's not going to be the jet black if you apply it properly, and I was not applying it properly in the first place. You may want to consider a SMART technique. I'll show you some cases because those are generally more exciting. This is a young individual that came in with a hypoplastic molar, tooth's just erupting, already has a cavity. She was not cooperative. She would not really sit in the chair or open. We were lucky to get this done. We applied silver diamine fluoride and then also twice and then a glass ionomer over that. And that bought us some time. And we also did that for her lower molar, and now she's got a nice result. We were able to restore that with the stainless steel crown at a later visit, and she's going to have a long life with that tooth. This is another individual that came in, would not even sit in the chair for me, and she's got this buccal pit on this tooth that's erupting. We had poor isolation, poor cooperation, and probably a moderate caries risk. This is the only need she had. And we ended up applying silver diamond fluoride twice and placing glass ionomer. And we were seeing her every 3 months. The mom came from an hour away and she said, I don't want to come see you anymore because I'm traveling too far and it's just getting too much. And I said, okay, that's fine. Let's sedate your kid and fix this. So we did a conscious sedation, and it's probably the most beautiful conscious sedation that I had ever done. She just was an angel. We sat there for about 30 minutes doing everything, and had a very nice outcome restoring this tooth. As far as the moderate sized lesions, here we'll get into more like class 2 lesions and some of the things you can do. Composite or amalgam or bioactive material if they're low risk. Again, high risk, you may want to consider an RMGI in these cases. Just to I know it's not ideal, but that may be something that you want to consider for these lesions. Here's the one that I showed you. This was an individual who had an occlusal lesion that was a moderate size. You can see afterwards here, recall after restoring it, and a very nice outcome. The one I showed you earlier, that was also the class 2 here. We did indirect pulp therapy here. She has a year later. Very, very nice outcome. And she was a low risk patient, so we treated her with composite. If we look at posterior restorations of permanent teeth that are a little bit bigger with enamel defects here, you can see a hypoplastic molar. Also down here, you may want to consider preformed metal crown in addition to the amalgam composite and bioactive materials. And for the high caries risk, you definitely may want to consider doing an alloy or a bioactive material. I tend to lean more towards the glass ionomers and RMGIs if we're doing kind of that smart technique to just kind of get these kids by until we can get them comfortable. If we look at matrices, there's quite a variety on the market. You can use T-bands and Novo bands. I think those work great for permanent teeth. Tofflemeyers are great for alloy. And the other two options are an auto matrix or a sectional matrix, really what I like to use for my posterior composites in adolescents and in permanent teeth. There's different types of rings. This is the system I use, the composite tight rings. We got a tall, a short, we got a wide prep, which is new, that can help you if you've got an extensively broken down tooth. They're going to form a really tight contact. They don't slip because of the rubber on there. And you have a wide variety of matrix options. I will say I trained with these in dental school, the original G rings, and I still keep these on hand because sometimes I can't get the bigger ring on. So keep that in mind. As far as the matrices, a full curve matrix band, they make a few varieties. So you can use a 3D Fusion that's got an anti-stick component. I tend to like the firm ones just because I'm a little more conservative in my prep. And they also have different sizes to match the size of the preparation that you have. These are the ones I like. They're better resisting load. And if you're not going to be a very big prep and you just kind of barely break the contact, this is going to be better because you're not going to be, the other rings will, or matrices will bend and it's going to be more difficult for you. So I like these to be a little more conservative. I do a lot of slot preps on premolars and molars if it's very minimal with what I like to use. So that's kind of my go-to. The other ones are great if you're a little bit bigger and you like to prep a little bit more. The wedges are also important. These are really cool because they'll adapt to the tooth shape. The rubberized area will adapt to it and then it springs back. These fins will lock everything into place so you can have a nice matrix. The inner core is really firm, so you're going to get that separation still, but you're going to get a nice adaptation. And then this is also going to, with it locking into place, is going to reduce the amount of contamination that you have from blood or saliva, which is going to make your materials work better, especially if you're using a rubber dam. So the technique will be to go ahead and place your matrix bands. I know these are primary teeth, but I'm going to show you a video here in just a second. You can place your wedge next, and then you want to place your retainer or ring on the preparation. And then you want to go ahead and, if you're going to restore back to back, you want to restore one and then take out one of the matrices and then restore the other. So very nice outcome here. I did this with a very dark shade so everyone could see, but a beautiful restoration on those teeth. This little video I want to run through with just a few minutes here. This would be a situation where we have a large carious lesion and we have a pulp exposure on a kid and we don't want to do endo. One of the things we can do is have a very nice aesthetic outcome depending on the carious risk for using this system. So you can go ahead and place your ring and then place a wedge. I like to hold that matrix C in place. You can place it with one of their applicators or your fingers or cotton tip applicators. Here, this is actually biodentin in this case. I usually disinfect, I didn't show that, with 6% sodium hypochlorite. Go ahead and place biodentin with, or another calcium silicate, another MTA product with an amalgam carrier, and then condense that with just a very moist cotton pellet so it doesn't stick to it. You want to go ahead and let this set for the 9 to 12 minutes if you're going to use this material. And then you can go ahead and do your, I didn't show etching, but you can do your etching, your bonding right over this material. So after you let it set, that's going to reduce the need to come back and wait for some of these calcium silicates. Here, when you place your band, you're going to open the ring and then push it into the wedge first and let it swing back into the other tooth. That's going to prevent you from dislodging your matrix C. You can do a selective etch, total etch, or you can also do a self-etch technique with the zip-on, the universal adhesive. You'll light cure that for 10 seconds, and then you can start layering your composite in over the material. Here, I think I used like an A3.5 just so everyone could see the shade and the placement. So 2 millimeters for this composite is going to be the depth of cure, and you know it's going to be something you have to spend a little time on. You're going to want to layer it against the walls to reduce that C factor or that shrinkage that you might have. But it's going to be a nice thing. I think I'm going to skip through some of this just so we're not on this video for so long so you guys can see the end result, and then I'll show you some other cases that we had. But a very nice way, especially for kids that don't have access to the endodontist to do this, you know, calcium silicate MTA, pulpotomy, direct pulp cap kind of thing, and just reduce their need to see the endo. And I'll show you some cases. We'll explore this a little bit more in the next lecture on the restorative basis and just show you some, I'll tease you with, here's some cases and some outcomes that you can have for your patients, because, you know, minimally invasive is the way we are trending in dentistry and pedo, and that's going to prolong the life of a lot of kids and just make things better to do less invasive things, less sedation for kids at our offices. And I think that's a better outcome for our families and our patients, and to reduce dental fear and change the way people think about going to the dentist and actually love going. So we have lots of kids, and I love getting the reviews of the kids coming back and saying they just love you. And we actually had 2 parents last week at the hospital that, I know it's been a tough year, but they told me that it was just the best experience that they had with my staff, and they didn't have that as a kid, and that's just what you want to hear. So here you can see just the final cure of this, and we'll go ahead and take the ring off, and you're going to get really nice contacts with this. This is kind of the bread and butter of your practice, the class 2 for a general practitioner. And when you can do a nice contact and a nice occlusal result, and you don't have an open contact, no one wants that. Just very predictable each time you do these. And here we can go. We're going to remove the retainer, and then this is just so tight. This is just on a Typodont too. It's not even on, you know, the natural dentition. So we'll go ahead and remove our wedge, and then here you can see I'm going to attempt to remove this the matrix, but I can't get this out. I know cotton isn't very good, but I get my fingers in here, and it ends up, the contact's so tight that this ends up ripping. So you're going to get a very nice result, you know, for contacts and everything, and, you know, just nice flossing through and a good contour, and very minimal you're going to have to do afterwards if you do a nice job. So really enjoy using a matrix system that works well for permanent teeth at my office. These are some tips. I want to say get organized. This is my setup. We have a blue cassette for operative. You want to get everything color coded for your office. Here you can see we've got Hue Free IMS cassette, Garrison. We got the rings I like, the Composite Titan, the original G rings. Those go in a Hue Free parts container, and that goes along with our operative setup for when we're doing these cassettes, so there's no confusion with the staff. Start with a small lesion. Don't pick up like a big, huge interproximal lesion on a molar when you're trying to pick this up first. It's going to be a learning curve. So here you can see on the maxillary right premolar, you can see here a DO that you could definitely pick out for an easy case. Start small with this. I would advise you to use wingless clamps. If you got wings on there, it can make it a little tighter for the band, or the matrix to seat over that, and as well as getting your retainer on. Do not do this. Do not do not stack this up. This is a nightmare. You're really using the wedges for separation, and also that retainer is going to push the teeth apart too, because it's really compacting it. So no more than 2. So if you have to take some steps and do some things at a time, you're going to get better results if you do not try to do this. Also, if you're doing back-to-backs, restore all the MOs or all the DOs first. That will just make it so much easier on you with doing these restorative procedures to not have frustration about an open contact later. You can also pre-wedge, so if you're going to do the second molar, go ahead and put the wedge in and then start prepping. That's going to start giving you better separation so you get a better contact. Like I said, keep the original rings on. This was a case I tried to get the short ring on and I couldn't, so I had to go back to the original ring. It just was not ideal. I'll show this case later. If you got a wide prep, offset the band more to the side of the wider prep, and then also wedge from that side. So the wedge is bigger as it comes through, so that's going to give more expansion and compression for wedging from the wider side of the prep. Like I said, this is really the bread and butter here. A few cases. Here we've got, you can see some cavitated lesions on the second molar, which the retainer's on, in the second premolar. You can see after preparation, I'm sorry about these photos, I have a poor intraoral camera. You can see this is the case I showed you earlier, etching, and then going ahead and bonding and restoring these teeth with nano composite. Here you can see afterwards, here you can see just, this is after, before we finished, we took everything off. You can see nice ideal contours. We have a little bit of, tiny bit of flash to remove on the lingual of both the teeth. But here you can see a very nice result that this patient's going to have for a long period of time lasting them. Here's another case. We're doing an MO on the first permanent molar. Rubber dam isolation again. Very, very conservative preparation here with this tooth. We're using the Garrison system again, and the wedge and the matrix. And then a nice result, we sealed that incipient decay on the distal. Very conservative, minimally invasive dentistry. And before and after, the contour is almost the same as we had before. So very nice results with this system. Jumping into pulp therapy, this is what we're going to cover more, a little bit more in the hands-on, because I think this is what I'm passionate about. Here you can see if we got pulp therapy completed and we've got small lesions that we can fit a small occlusal access, maybe being more conservative with a composite or an amalgam or a bioactive material. Here you can see on the right, we've got a large alloy, almost half the tooth is missing on this adolescent. And at my office, if they need full coverage indirect restorations, we do it. And she had a tooth that was cracked here, the premolar. These are both, in a kid, these are both indirect crowns that I did. There's no reason that a general dentist can't do this on a kid that's still growing. They may have to be replaced later in life if the margin's showing. This one elected, she actually said she wanted gold teeth because she liked Aladdin and said he who made the gold make the rules. So keep that in mind, that you may want to also consider doing that for your patients to prolong the life of the tooth. And stem strip crowns aren't a bad option, but to me, if they're cooperative and we can get through 2 visits of indirect crowns and they're willing to show up again, that's kind of my choice for some of these teeth. Here you can see a deep lesion here on a permanent first molar. This was treated indirect pulp therapy with a glass ionomer here, 6 months recall. Didn't get recurrent decay, very healthy roots. This is one of my favorite ones, indirect pulp therapy. This is a young 6-year-old, and I wasn't sure we're going to get through everything at once, so we did her teeth here. Here you can see caries remaining. We ended up restoring her with composite. Here you can see indirect pulp caps on all of her 6-year molars, permanent first molars. Here she is on recall on the left side, and here's the right side. And she came in, actually, they tend to come in right before the lecture, but she came, these x-rays are from 6 months ago, but she came in yesterday. and I recognized her name. And these were all immature apices with indirect pulp therapy. And we haven't had to redo them. Been an excellent result for your recall. Apices are closed. Same thing on the other side, no failures. Very successful. You can be successful with indirect pulp therapy. Here's a deep lesion that had irreversible pulpitis. I couldn't get the bleeding controlled, so we ended up doing an apical barrier with biodentin. Extensive tooth loss here. You can see on the coronal portion, we removed the gutta percha down, and then this was bulk filled all the way back up with composite to strengthen the tooth, trying to avoid a permanent crown. Very low caries risk kid. She didn't really have anything else, so being conservative with the composite on that. And the composite is going to also help build strength being filled all the way down the canal versus a post, which might weaken the tooth. Here's another young individual. These are kind of not frequent flyers at the office. They only come in, this family only comes in when they have pain. So here you can see a second molar here, deep carious lesion. We ended up doing direct pulp cap with MTA at the time and restoring that with composite. Very high caries risk kid here. Here you can see came back 2 years later and recurrent decay. We look at the bite wing actually, look at the dentin bridge that's formed underneath that calcium silicate, even when we had pulp exposure. So we get to do it again, and you're not going to fool me this time. So here we are 3 years later, beautiful stainless steel crown restoration for this kid. They don't show up very often, so if I'm looking at doing a lab fabricated versus a stainless steel, I'm not going to eat the lab bill. I'm going to do stainless steel and we can kick that down the road. Another individual here, this is one that I made a mistake on, came in and hypoplastic molar, was seen by an endodontist prior and was getting recurrent decay here on the distal, and I placed a composite on that ended up failing, and we ended up having to come back and place a stainless steel crown or full coverage on this kid to get them by. So you can see also new decay here on in the mandibular quadrant as well. So a little bit more of a higher risk kid. Probably would have been better off if I didn't place the composite, would have gone with full coverage in the first place. Here's another deep carious lesion. This one, we don't have adequate remaining dentin thickness, so we did end up completing a pulpotomy. We can talk more about this with the MTA. This was a smart MTA from Sprig. And this I just restored the same day with Riva Light Cure HV. And we're going to come back, see how this is doing in 6 to 8 weeks, and then go from there for full coverage or a more definitive restoration. They didn't come back for a year. Here you can see they came back nice development. Here she is again. This is initial. You can see the apical development of vital healthy tooth. I did treat her with a stainless steel crown now, and she's going on 2 years with this tooth. This is what I'm excited about as well, indirect pulp cap technique. This can be used with smart technique with the Riva Star, and you can have a very aesthetic outcome. But it's going to be incomplete caries removal. We're going to leave decay and avoid the pulp exposure. You can place Riva Star and then go ahead and place a glass ionomer and then also composite over that if you'd like, or restore it with RMGI as well, or an alloy. There's 2 different types, 1 visit versus 2. We know now that you're better off just doing 1 visit for all this therapy and being done whatever you plan to be your final restoration. You're better off placing that at the same time. So this is the smart technique. I've got a video that I'll share with you. I don't have time since we shared the other one tonight, giving everyone equal time, but this is the smart technique, rubber dam isolation, selective caries removal. You want to etch before you apply the SDF. You apply step 1 for 60 seconds, step 2 for 90 seconds, place glass ionomer, and then restore with your material choice. Here it is after placing it. We don't have the staining that you see. We don't have that black that I showed you from before when we do the second step. Been doing this quite a while at my office. Here's the contralateral tooth. This one was treated with a bulk fill with just an RMGI and not a composite over it. No staining on there as well. And I think if you apply the second step liberally and very effectively, you can achieve aesthetic outcome, especially when doing indirect pulp therapy. If you do not do adequate time or you miss a white spot, you are going to end up with a stain. So use this judiciously, rubber dam isolation, proper isolation. You don't want to get this stuff on the gums or the tissue. It can very well be caustic and burn with a higher pH, but if you have adequate isolation, like the rubber dam, the gold standard, you can be very aesthetic with this, increase your bond strength glass ionomers, and reduce your sensitivity. So that's what it's really FDA approved for. So keep that in mind. A few more cases here. We'll cover this more. Here's an initial deep carious lesion, inadequate remaining dent and thickness, and we end up doing a direct pulp cap on this tooth with the pulp exposure. This kid's one of those ones that doesn't come in. They didn't come back in to get all that tartar off. Here's the post-op to document. Here they came back with another toothache on a different tooth, and we got our 2-year recall. Outstanding treatment, no endo needed. Some of these other deeper ones, here's another deep one here on the permanent first molar with the PA showing the immature apices, and here you can see post-op and direct pulp cap, and you can see apical development here. Another deep carious lesion here. We had a pulp exposure on the mesial, placed an MTA, smart MTA product. This one I just placed a bulk fill of RMGI, so let's see you back in 6 to 8 weeks and see how you're doing. They didn't come back. Here you can see on the occlusal surface, you can see the wear already happening at 6 months here, but we're having a nice pulpal outcome. I just want to share with you here, closing down at the end, another mistake that I made. This is another deep one. Probably should have extracted this tooth in the first place, but we ended up doing MTA pulpotomy and placing an RMGI. There's just too much of that tooth missing and ended up having a fracture. We got nice pulpal therapy. We don't have any apical pathosis, but this tooth now at this point is unrestorable. So not the most fun surgical extraction I've ever done. I'm going to move into some questions now, but I do want to cover for your webinar code. If you're US only, this is not going to work on the outside of the United States, but within the US, if you want that smart technique video for that case I showed you, it's about 6 minutes long. You can text REVA to 31996. That'll give you the registration code for today to enter. It'll also give you a link to that video, and then that will also give you a link to that registering for the hands-on course, which we're going to cover a lot of different things. We're going to do an upper quadrant type on. So I'm going to cover with you doing the REVA Star and direct pulp therapy, the REVA glass ionomer over that, the self-cure HV, which you can use over that, the Luna Composite and the R Easy Flow for small occlusals, and then also an anterior strip crown. And we're also going to get into some hands-on with the Garrison system that I use at my office, the fusion bands, the matrices, that whole system. We're really going to cover it all, and then they have a nice product called the VariStrip where we can demo a small class 3 lesion. There is a fee for just the materials. It's $295 for that. To cover the cost of materials. We'll do it in the afternoon on a Friday. I'd love to have you come join me. Also, you'll be getting your CE credit for that as well, included in the fee. So if you want the code here at the top, WB1120A, and also if you text that number, you can get that code. Like Kevin said earlier, they're going to email you, and you'll have to take a little quiz. That should be pretty straightforward for you. And then include your AEGD number. And then if you don't receive the credit, check your spam folder. You can also email webinar@garrisondental.com. If you want to contact me, you can. Here's my son again, Dr. Jared at arcticdental.com. I'm happy to help out if there's any issues. So let me see if I can find the chat filter. If there are any questions, I am happy to cover anything right now.
Dr. Johnson, I've got that up on my screen here, so I can go through some of these here for you.
Let me see. I can't see. I don't know. I minimized something here so I wouldn't see it during the thing. I see a chat, but
yeah, it's in the questions tab.
Okay, so let me see. It's not in the chat, so yeah. I don't think we went over this the other day. So I got drawing tools, audio.
The first question that Dr. Cook asked here is there separate ADA codes for when you're using an RMGI versus a composite? And how do you explain when they have to, when you have to redo one a few years down the road? How do you explain that to the parents?
Yeah, so that's a great question. So there are not separate ADA codes. Let me go back. I think I skipped a slide quickly. There's different ways you can get around it. At my office, with the RMGI, we do bill for a composite. There is composite in there. So let me get to the billing codes. But what I'm finding is in these high-risk kids, that we're not having to redo the work again within the 2-year period that the insurance will pay for it. So I'm not having that conversation with these families. Oh shoot, I was just on the slide and I'm not having that conversation with the families. I mean, we're placing it in the right clinical situation, so we're not getting recurrent decay in those situations, and we're not having to have an issue with that. We've had more issues with parents that are, pushing for different things. Let me see. Here's the billing codes. If you wanted to be more conservative about it and these are the billing codes for like a smart technique. So you definitely could bill for a protective restoration. I'm planning on this being definitive, so I'm billing for the composite code because I'm anticipating this to last longer than the composite. If you feel like you're not going to get that result, which I haven't seen, you could bill for a protective restoration or in the primary dentition, an interim therapeutic restoration. Those are lower fees. And honestly, we do this at my office if it's the right situation. If I'm doing something like this, that is not definitive for me. I'm billing for an interim therapeutic in this case, in this one that I showed you. That I'm not doing billing for a composite. I feel like that would be unethical. I'm doing this to buy the kid time so we don't have to sedate the kid. I want to build a relationship. I want to have minimally invasive outcomes, and I've had them. I mean, it works. It just takes some time, and you got to find out what's best for your office, what's best for you. But it also, like these situations where we have a primary tooth that's going to fall out and it needs a restoration or an extraction, the restoration's easier. I'll place a Hall crown and bill a sedative on it. I don't care. I just want to take care of my patients, and you do that, and they're going to love you, come back to you, and just tell them that. If you're going to discount it, just say, hey, this is normally what it is. I don't think this needs to last long. It does need to get done. This is going to be a better experience for your child. We're going to bill you for a temporary filling. Like, they get that there's less cost with that. That's a great question.
So another question here, would you still crown teeth on adolescents with high caries risks?
Absolutely. Would I crown them? Yeah. I mean, if they're high caries risk, and especially with hypoplastic molars, if they've got large caries lesions, I wish I would have updated this. And I'll take the first molars out and let the second and third move in. And I can show you cases I've had very good success doing that, especially maxillary molars, lower mandibular first molars. I try to save them because it's not as predictable. The timing is more important. But yeah, absolutely. If they've got a hypoplastic molar, large caries lesion, and I want to save the tooth, I will definitely place a stainless steel crown. Or we've had kids at my office that are cooperative, and we've done this nerve treatment with the MTA products or done indirect pulp therapy, and it's lasted them a while. And I know that's not going to last forever. I'll go ahead and do an indirect restoration. I still do that. If that's what the kid needs, then that's what I'm going to do. My general rule is I want to have the tooth erupted mesial and distal to it before we do that. So we have a more predictable outcome. It will, as they grow, super erupt. We can deal with that margin later if they want to have it cosmetically replaced. But a lot of these kids in the posterior teeth don't care, and if they're anterior, not a lot of them have that high smile line. So that's a great question, though. But absolutely, do stainless steel crowns on permanent molars all the time. Do permanent indirect restorations on teeth. And if you want to get into an onlay or an inlay, those are great options too to prolong life. I think it's probably even more conservative than the stainless steel crown is doing an onlay if you're a general dentist and you have that repertoire.
Quick shout out here to Dr. Bertolotti, who joined us here this evening. Some of you may know him from his lectures and articles and stuff. But question is, does biodentine seal the interface to dentin? No gap.
Correct. So if you look at some of these calcium silicates that are out there, they actually penetrate the dentin tubules, similar to the SDF product that I was showing you earlier. And the microscopy is amazing. I'll add that video into the hands-on one. But if you look at the penetration of these chemicals, there's one study, I think it was Kim Jong-kun, that actually took teeth and infected the root canal with ephecalus, the endodontic worst nightmare. And then they treated it with calcium silicate product. And then they did scanning electron microscopy. And the calcium silicates, like the biodentin and MTA, they are penetrating the tubules and they are entombing the bacteria. You see a crystallization layer around the bacteria. And I think that's why these products are so successful, is that the science behind them, when you look at the study that's done in the lab, I think that's happening in the mouth, and that is why I think it's a way better product for pulp therapy than calcium hydroxide. I think it's a great, I would not, that's one of my favorite products is the calcium silicates. I would not practice without those. I'll show you a bunch more cases in the hands-on of avoiding endo in these high-risk kids in my office, and that's just the best thing for the patient. It's amazing what you can do. Regrow teeth, save pulps. I mean, it's just crazy.
So we've got, do you recommend any biomaterial for indirect pulp cap?
So right now, the literature, there's no science. We've got the studies on the calcium hydroxide, a glass ionomer, and an RMGI. They all show reduction in the colony forming units on re-entry. And we're saying now that re-entry is not necessary. The two new products that are out there that could be beneficial that have not had in-depth studies are SDF, similar to Riva Star. Number one, you're going to get, with that product, you're going to get action on the bacteria and also fluoride uptake and remineralization and also post-op sensitivity. That's what it's FDA approved for. So you'll get less of that. The other consideration is like a Biodentin or MTA product, calcium silicate. Like I said, those entomb bacteria and go into the dentin tubules. So that could be another advantage. So these two products have not had the same studies that have been done on re-entry that some of our historical indirect pulp capping products have had. I'm excited about it. We'll see what happens. I don't know if it's going to make a difference, but if it does in either sensitivity or outcome, I think it could be an advantage to use in your office.
For indirect pulp therapy, are you using calcium hydroxide or mostly biodentine?
No, so mainly I'm using, either a calcium silicate like Biodentin or Smart MTA or Neo MTA, one of different products fit differently, or Riva Star. Definitely using those. I have shifted away from using calcium hydroxide. I don't see the advantage to using it from the studies. You're equally as viable to just use a glass ionomer in those cases, but I'm seeing the bacterial entombment from the calcium silicates, and then also the fluoride releasing post-operative sensitivity and the mechanism of action on the bacteria that are left with the silver fluoride products. So that's kind of the direction I've headed, and it kind of, also depends on cooperation. If I don't think I'm going to be able to, do the proper application and reduce the staining, then it's maybe better off to use calcium silicate. Whereas if I've got a cooperative adolescent, maybe the Riva Star is going to be the way I go. So cooperation's got to be key. I don't want to get in a situation where we have an unhappy parent and a dark tooth and I didn't do it right. And I want to have an aesthetic outcome and promise what I can deliver.
Let's see. What is the duration of SDF application? Some dentists advocate light curing, then restoring it.
So the application process, so most of the mechanism of action happens within the first 3 minutes. When we look at the study that Dr. Oyes did, it's 60 seconds and then it tapers off. So that's why the AAPD guidelines, which are available on the AAPD website, recommend a 60-second application. Now that is not always practical. You'll see you have an uncooperative 2-year-old, you're not going to be able to apply it for 60 seconds. So in that case, we will apply it and then immediately after apply a fluoride varnish on and have them back in 2 weeks and do the second application. If things are going well at that point, then we will go ahead and place this SDF again and then a glass ionomer over it, just to cover that up and prevent food impaction and prevent that lesion from growing. As far as light curing, the light is going to make silver oxide, which is going to cause the staining. So if you're using the Riva Star, I would recommend that you do the second step. And after you've done that second step and you've already precipitated out the silver iodide instead, which doesn't cause the staining, you can go ahead and you can do whatever you want. You can place your restorative material on light cure that same day and not get the dark staining. You'll still get some discoloration, but it's not going to be the same as if you just used the first step alone. So I hope that sheds a little light onto that question. That's a great one.
Do, can you use the SMART technique with SDF? I have to apologize. We just got into the middle of a huge thunderstorm here, so you may hear some background noise when I ask these questions. But can you use the SMART technique with SDF?
Absolutely. Just this case, I just showed you. It works great, especially on uncooperative kids. Recommend again, if they're not cooperative and you're trying to buy some time, go ahead and place STF once and then come back. If they're not cooperative, I don't do the second step. Just skip that. Have good isolation. Come back in 2 weeks. You want to do 2 weeks so you don't have too much silver content based on the EPA regulations for drinking water. Place it again. If things are arrested, put a glass of Ionomer in there. Put self-cure HV in over that. And then see the kid in 3 months. And if everything's holding up and you're getting cooperation to be better, go ahead and move forward with a definitive restorative plan. If not, then we know we got things stabilized and we're going to put that kid on a 3-month recall until I get them to where I want to be. If things are not progressing the way I want to and things are getting worse on other teeth, maybe we do jump into sedation. So, but we'd rather not do that if we don't have to, especially on, young kids. Did we miss you, Kevin? I don't know if you're still, let me see if I can.
I'm sorry about that. Yeah, I
We had that
muted myself
thunderstorm
again.
earlier there, and it scared me. We were working on a patient, and we had a tornado watch, and one of my staff said
Oh,
it was a
good grief.
tornado warning, so I got a little worried.
Yeah, especially if you got them partially sedated or something. You throw them over your
No, they
shoulder
weren't.
and
I
run
just
down to
didn't
the
want to start
basement.
something and have the power go out, and then we got a kid that's numb, and I didn't do anything. So
Yeah, yeah, goodness. Well, I think we've got everybody taken care of here this evening, so we'll send out that email here in just a few minutes. We paused on that as we were answering questions, so we'll go ahead and get that email sent out in just a couple minutes.
let me get to
Any
that last slide if anyone needs it here. Yeah, this has been a lot of fun to come out, Kevin, and it's challenging. This is not the easiest thing to discuss, and there's a lot that goes into it from a restorative standpoint, but there's a lot of good products that are out there that can help you, and you can have really nice outcomes for a lot of your patients using a lot of these systems.
Well, and hopefully some of the folks that were with us here will join us for the hands-on in a couple of weeks. That's going to be a great session, and we'll be sending out separate invitations for that as well. So if you didn't catch that along this evening, we'll be sure to get you an email with the registration information for that course. So
Yeah, if you text us, Riva to 31996, you can get that link. And then also, Kevin, I did reach out to Septnot. They're going to throw in some biodentin, so we're going to play with
great,
that too. If you
excellent.
want to practice, I think we got an anterior tooth that we're going to have a class 5 on that's got a little bit of a hole. We can perform a partial pulpotomy. And if you have a kid with trauma, it's a great service to avoid endo, especially with these immature apices. We'll go through placing that and then restoring it with a composite strip crown. Should be a lot of fun in addition to the other stuff we're doing, and we'll share that video and everything. So should be
That's going to be
fun
a
and
busy session.
things we talked about. So I really enjoyed being on tonight, and I'd love to have everyone come back and do more and spend and do some roll up our sleeves, I guess.
Yeah, absolutely. It'll be a busy session. A lot of restorative materials to work with during that. So, all right. Well, we're going to go ahead and close things off here for this evening. Thanks again for joining us. Hopefully, you jotted down that webinar at garrisondental.com address if you have any questions, and we'll get your email out to you with the quiz and eval in just a few minutes. Thanks so much, everybody.